So sotatercept it's a totally new type of drug for pulmonary hypertension. I think that's one of the reasons it's so exciting. So already we have a number of drugs that work as vasodilators, so they will help to reopen some of the pulmonary arteries that have narrowed and closed down. But they are really a sticking plaster for something that's already happened. The difference with sotatercept is because we understand more and more about the underlying biology of the disease, means that we can focus in at an earlier stage and stop the disease progression in the first place. So it's much more a case of getting to the root cause of the problem rather than treating the consequences of it. And that will be the first time that we've really seen that. So we've seen a lot of the data now from the trials, and recently again more has been published, and it does all look reassuring. But that's really just the first stage that we think we're onto an effective drug. So in the UK, for example, it now has to go through the MRHA to be regulated first of all, to say that it can be licensed for doctors to prescribe it. And then after that it goes through a process with NICE as more of a cost effectiveness analysis, so that we can start to understand, are we getting good value for the drug? And then once the approval process is complete, then we can start to use it. It's very difficult to estimate how long that will be, but roughly you would expect within a couple of years from now.
Sotatercept arose from some of the work that had been done in genetic forms of the disease, and in particular in a pathway known as the bone morphogenetic protein type 2 receptor, or BMPR2 pathway. And essentially it works by changing the expression of proteins that we know underlie the familial forms of disease. So it's not a vasodilator, it doesn't work by just opening up vessels, it seems to be working more directly on the underlying problems or problem proteins that are causing the disease in the first place. And so since we last spoke, the results of the full big trial of sotatercept have been released, and so we've been able to comb over them, and when we last talked we were all quite excited about the press releases that happened, and the paper in the New England Journal definitely confirms that excitement, because the drug seems to be having a very significant effect in a very wide group of patients with pulmonary arterial hypertension. So it's an injection, and it's a monthly injection. So it's going to be slightly different to the currently available therapies. So not as committing as perhaps epoprostenol or treprostinol given intravenously or subcutaneously, but not as convenient as some of the tablet forms of therapy. So I think this is a really big step forward, because although the last 20 to 30 years has seen a lot of steps and changes in what the treatment options that we have for pulmonary hypertension available are, all of those drugs work in the same sort of way, so that the benefits have been incremental. This is a different, this appears to be a different mechanism, and it does a different thing, and actually the results are as positive as anything we've seen for 20 to 30 years, despite the fact that the majority of patients who were in the clinical trials were already on a significant therapy package. So this appears to add additional benefit on top of the therapies we already have. And I think that's the thing that's exciting most of the field at the moment. It almost definitely will be in combination with other therapies, but we're getting a little bit ahead of ourselves yet, because at present it's not been licensed anywhere around the world yet. The things we know that are going to happen next are that NICE, the National Institute of Clinical Excellence, are going to do an appraisal of the drug next year, starting about March, and that will take a number of months. Probably won't be finished till towards the end of the year. And that is where they will decide what they think the added benefit of the drug is, and balanced against the cost of it. So we're not there yet. We're not going to be there this year, but we would expect some decisions to be starting to be made for next year. And it's important to remember that we still have some open questions about the drug, about who it works best in, and about how it should be administered. And as a result of that, there are still open trials across the UK that most of the centres are signed up to. So if you are interested in trials in sotatercept are still ongoing, and just go and speak to your centre to see if you're eligible for them. So we don't know yet what the decision of both the regulatory and reimbursing authorities are going to be. So we don't know who or where it's going to fit. It will be within a group of patients that are similar to the patients that the drug was trialled in the big trial. So it will be group 1 pulmonary arterial hypertension. But beyond that, we don't know what specific limitations are likely to put and where it's going to fit in the kind of treatment algorithm. But it almost certainly won't be upfront because that's not the patients that were treated. Patients were all on established therapy. So it's likely to be in a group of patients who are already on a significant amount of vasodilator drug and almost certainly will be an add-on therapy in that context. So this is the first drug really that we've had in pulmonary hypertension that works by a different mechanism than all the vasodilators. So it tells us that we can alter disease beyond just opening the vessels up. So I expect that there will be a subsequent set of new drugs coming on the back of this drug. So this is what will be the start of the next phase or evolution in how we treat patients. And so I think we can be pretty optimistic that the last 20 years have seen a change in life expectancy and quality of life for patients, and that the next 10 or 20 years we should be seeing further gains still.